We can start now.
Yeah. Good evening, everyone. It's a wonderful opportunity again on the today, the eve of 29th May, that we are all together to discuss the next session in the series. Today, we'll be discussing on the upper limb management in cerebral palsy. We all know that upper limb is a major neglected portion in cerebral palsy. We usually all conferences everywhere we actually speak on lower limb management, and I think there are quite bit of PMR's faculties who are very confident in managing lower limbs. Even I think in PG career also, including myself, we always been discussing mostly on lower limb. So upper limb management remains by and large neglected, and when it comes to the distal hand component, it is even more neglected because the precision is required and the assessment of the precision is quite bit difficult. Often we find it that among the therapists also, or a team of rehabilitation members, they also find it difficult, starting from the well-experienced nursing staff to the postgraduate students, even consultant. So we have thought that why not to speak and discuss over upper limb management of cerebral palsy. So the cerebral palsy upper limb management is very tricky because it's not just the spasticity. The management includes a lot of other features because 6 to 7 types of sensations, various movement disorders. Even if we just concentrate on spasticity itself, there are various types and varied features of spasticity. We can actually change the result. Also, the dominance of the hand is also very important. So all this is going to come. Today's guest lecturer is Dr. Pavitra Kumar Sahoo. He is head of the department of our institute. It is SVNIRTAR. And I'm very much lucky to invite him. I meet him every day, but I'm very lucky to see him operating and also discussing things with him. So I invite Dr. Pavitra sir, without wasting time, to elaborate on the management of cerebral palsy upper limb. Thank you, sir.
Thank you, Abhishek. Good evening to all participants. As Abhishek said that this is really neglected topic as far as CP management is concerned. There are a wide way of management, starting from management by splinting, management by spasticity management, by buttocks injection or botulinum toxin injection, or by surgical means also. It's a big chapter. So probably today it's very difficult to cover all the aspects in a single lecture. So that's why we have confined the lecture to the basic assessment of a cerebral palsy hand and upper limb, including upper limb, as well as the principle of surgical management. I mean, what are the simple procedures by which we can manage a cerebral palsy upper limb? So before going to detail, let me share my slide. Abhishek, is it visible?
Yes, sir, it's visible. It's visible.
Okay. So today's discussion is on evaluation and principle of upper limb management in cerebral palsy. I suggest all participants please actively involved in this discussion. Wherever you find any difficulties, please don't hesitate to ask us. We'll discuss in detail. And there are some criteria and assessment procedures I have collected from different articles, and I think it will be definitely helpful for everybody. You can keep a set of these data or tables for your future reference. So without much wasting of time, let us start with the topic: evaluation and principle of upper limb management in cerebral palsy. Cerebral palsy, as you all know, this is a non-progressive central nervous system lesion that usually occurs due to perinatal insult to the brain. Though the insult is static to the brain, the lesion in the brain is static, but the musculoskeletal pathology is progressive in nature. So most of the time, the major problem dealing with this or major pathology behind this complications of cerebral palsy is because of spasticity. This spasticity leads to shortening of the muscle units, which in turn causes fixed contracture and eventually leads to different musculoskeletal changes, such as torsional abnormalities of long bones, joint instability, deformity of the joints in long run, and as the child advances with age, the child, the adolescent or adult age, the patient develops degenerative arthritis. So this evaluation of management of upper limb in cerebral palsy is often neglected and always given a second priority. Ambulation being the first priority, management center around always around the lower limb deformities. Rarely we think about the upper limb. The first priority, even for the parents also, the first priority is ambulation. So long as they are able to carry their child, they will always concern about that, how the child will work. And because the child is small, they can feed the child. So they don't, expect any, major concern, showing any major concerns for the upper limb functions. They are more concerned about the lower limb problem. So our treatment management, our all the guidelines and all the way of management are mostly concerned or center around the lower limb management. But the upper limb management is a little bit tricky because it's a very, it's because the peculiarity in the spastic hand. It's not like a other type of deformity like in a paralytic hand because of lower motor neuron degeneracy. The complexity of the spastic hand is due to the fact that the muscle cannot be used as tendon transfer with the same efficiency as done in reconstructive surgery of hand in flaccid paralysis. So the tendon or muscles behave in a different way in contrast to the flaccid type of paralysis. And here the deformity is basically dynamic deformity. Whereas in flaccid type paralysis, static deformity, there is static contracture. And unless you have not properly evaluated before planning for any surgery or before taking the OT, you will be land in problem because all the deformities or the most of the deformities disappear after anesthesia. So a proper assessment, good evaluation will help you for treating the or managing the upper limb in several parts. So what are the things one must know before planning for any upper limb management in cerebral palsy or any spastic hand, any spastic upper limb? The extent of release is required because the deformity behaves in different way when it is patient out of table or out of anesthesia, and behaves in different way when it is with anesthesia. So a judicious release is required. If you release more, you may land with a weakness. If you release less, the deformity may recur. So there is always a balance between these two. Tension adjustment in the tendon transfer. It's not like flaccid type of paralysis. Here, one has to be very judicious. If you are, suppose you are lengthening flexors, you are excessively lengthening, your hand grip may poor. The whatever patient hard grasp earlier, he will lose the grasp. So the tendon adjustment, what are the tendon you are transferring? The tension at the during transfer is also important. Stability of the joints, the proposed tendon transfer would cross. So what is the status of the joint? If there is there any associated deformity, so deformity must be fully corrected around the joint where the tendon is going to cross in case of tendon transfer. So these are the basic things one must know, prepare, one must know for planning any sort of management in upper limb cerebral palsy. The spasticity and voluntary control of the muscles selected for transfer. This is peculiar or specific for a spastic hand. This is not required in case of paralytic hand. or in case of lower motor type of flaccid type of paralysis. So voluntary control is also important. What is the behavior of that hand? How the voluntary control is there or not? So what are the initiation of the hand is there or not? Unless there is no initiation by the patient side, whatever way you treat or you try to correct the deformity is not going to help you. So assessment of voluntary control as a limb as a whole is important. Moreover, the child use the hand during the bimanual activities. So that has again dominant side, as obviously the dominant side also one should see whether you are going to treat a dominant hand or a non-dominant hand. So there are certain challenges, especially when you are dealing with a spastic hand and cerebral palsy. Okay, the surgical procedure as such are not technically demanding. These are very simple procedures, everybody can do. But the thing is that unless you have properly assessed, unless your decision making is clear, and selecting procedure for the given patient make this field challenging. What exact procedure is required for a particular type of deformity or particular type of problems in hand function, that you have to assess. Whether static way, dynamic way. Dynamic way means you have to, you can take a video of a child, a video of the hand function. You observe minute by minute. You just see how the upper limb the child is using for his day-to-day activities. From that also you have to judge that what the things you are going to do. So because these are all dynamic things you will get during all activity of daily living. Unlike in flaccid paralysis, a static type of contraction. You know from the beginning that what tendon you are going to transfer and how you are going to manage it. But the dynamic one is always challenging. The results are rewarding not only in terms of improvement of the hand function, but also in appearance and personal hygiene also. So you may not able to get 100% function, but certainly will improve the appearance of the hand, certainly will improve the function of the hand, and also the personal hygiene also improve. That also matters. Okay, and which leads to a better self-image and permits better acceptance in the society. So it is not only that you are concerned about the deformity or the position. You are also concerned with the appearance, personal hygiene, and also the overall appearance of the child along with his body languages. Hand dominance. Yes, hand dominance also plays a role here. Whether you are dealing with the right hand or a dominant hand or a non-dominant hand. Normally, the hand dominance develops at about 2 to 3 years age, and it is fully developed by 6 years. That's why the timing of this surgery is around this 4 to 6 year age group. Now, what are the outcome of surgery? Yes, many of us are doing lower limb surgery, but if you compare the outcome of surgery for an upper limb in cerebral palsy, when you compare with the lower limb, it is not good as in lower limbs. The functions are not so visible. It's good, but it's not well visible, well appreciable like lower limb. It is very difficult to train a limb suffering from learned non-use, because most of the limbs are learned non-use. For a lower limb, they are forced to use. But in case of upper limb, they are learned non-use. The parents helps in feeding. Parents help in ADL activities. So these are all learned non-use. The child is not allowed to use his or her hand, but the child is forced to work. So in that way, it is different from the lower limb surgeries. Then retraining of the upper limb is more difficult because it lacks repetitive motor tasks. In case of lower limb working, the task is repeated each time the child try to work or started working. The task is repeated each time, each step. This is not happen in case of upper limb. That's why it is different from the lower limb surgery. And the other problems associated with the upper limb are higher incidence of dystonia, weakness, sensory impairment, and poor selective motor control that coexist with spasticity in the upper limb. These are major challenges which are not so frequent in case of lower limb. Dystonia, weakness, sensory impairment, poor selective motor control. Okay, so these problems are often associated with the spastic upper limb, which is not so common in case of lower limb. Upper limb tasks are very sophisticated and requires high level of coordination control, which is not required in case of lower limb. That's why the results are not well appreciable for the upper limb when it is compared to the lower limb. It is not that it is the result is not appreciable, or results are not good, or the ADL is not improving. It is improving, but if you compare with the lower limb, probably the things will be different, and there is a comparable difference between upper limb improvement and lower limb improvement because of these reasons. Coming to clinical assessment or evaluation of upper limb in cerebral palsy. So the most important things are the clinical assessment includes motor assessment, sensory assessment, intellectual function assessment. These are three important things before planning for any surgical correction. Then child's emotional state and fatigue level. That is the child. If you examine the child shoulder, upper limb, lower limb, finger, hand at one stage, child will not cooperate you. Okay, so you have to think that emotional status of the child, and because they land in early fatigue, they will not cooperate you. So you have to examine in a fragmented manner. All the lengthy examinations should be done in a fragmented manner. If the child is not still cooperative, then better to go for a video recording, which is helpful if you just record the video of dressing, self-care, eating, how the child is eating, how the child is dressing, how the child is taking brushing. So you just analyze the video. What is the problem child is facing during his normal day-to-day activity, normal activities of daily living. From that also you can assess. You can see that which group of muscles are spastic, whether a child is having a appreciable voluntary control or not, whether the child is having initiation of the limb or not. So these things you can get it from a uncooperative child by taking a video recording in different activities of daily living. So like we have recorded a video. Recently we have operated one child. This is the child who admitted in our ward. For the child is having a crouch gait as well as also upper limb problems. It's an adolescent boy, say around 14 years boy. So if you look to his why a video recording is required, because you will get exactly the dynamic problems because of spasticity, because of deformity, because of the imbalance around the joints, and you will find the exact problems that happen during his activities or daily living. If you look very minutely to this hand function of this child, if you see that the child is unable to extend the hand properly, and when he is trying to extend his hand, the hand is going towards flexion and ulnar deviation. See, and he is not able to completely open his fingers, and thumb is on the under side. It is in adopted and flexed position, which is hindering in grasping his foot. So he has a poor grasp because of this thumb function and incomplete finger extension, and he has also incomplete wrist extension, and the wrist is going towards flexion and ulnar deviation. That gives you an idea about that. There is insufficiency in the finger extensors, and there is spasticity of the flexor carpi ulnaris, and there is a thumb in palm deformity. Okay. So coming to motor examination part, in motor examination, the dominant and deforming spastic muscle, their strength and voluntary control must be assessed. The status of the weak and non-functioning antagonist has to be assessed. So both dominant group of spastic muscle, its voluntary control need to be assessed. At the same time also, the opposite non-functioning group, the antagonist group, that has to be assessed. Okay, just for your knowledge, I want to emphasize here, in case of other way of managing this hand, if the spastic group of muscles can be managed by buttocks and other way of managing spasticity by splinting, but you cannot augment the antagonistic or non-functioning group of muscles. This is the place where you need some sort of intervention, some sort of surgical intervention. So all modalities can reduce spasticity of the deforming muscle, but no modalities can help in strengthening or augmenting the function of the weak muscle. Unless both agonist and antagonist muscles are balanced around the joint, the deformity is not going to correct. And the child is definitely will land with a recurrence of deformity after a few days of surgery or few days of any sort of intervention. So that's why this surgical intervention is important for managing this augmentation of the antagonist group of muscles, a weak group of muscles. Then potential donor to substitute the weak muscle is available or not. Whether you can take that or not. If you are taking that donor muscle, is it going to cause any other complication to the limb? Suppose because of flex attitude of the wrist, you have taken the flexor carpi radialis, transfer to the dorsum to ECRB. So patient will develop with the extension deformity. So one must be very cautious about that. You have to search for other dominant flexor group of muscle like FCU. Okay, so potential donor to substitute the weak muscle should be thoroughly evaluated before planning for tendon transfer. Then global motor control of the upper limb as a whole, how the upper limb is behaving, whether the patient is having initiation for particular activity or not. That is a global motor control. Then voluntary control of various muscle groups, flexors, extensors, and radial deviators, ulnar deviators, all group wise. You have to think that how the voluntary control of each group of muscle is there. Then existing function and functional need of the hand for a particular patient. What is the need of the hand? Whether you are dealing with the left hand required for hygienic purpose, you are dealing with a dominant hand requiring for other ideal activities. Each muscle or a group of muscles are evaluated for voluntary control. The examinations begin with observation of the extremity at rest and also during walking, running, and activities of daily living, which represents the actual cosmetic and functional disability. So allow the child to perform certain activities, observe minutely his or her activities of the upper limb, and you can analyze that where could be the site of pathology. So it is not just looking at the range of motion or looking at the spasticity grade. So you have to look for a dynamic motion of the child or upper limb to come to a conclusion or to come to a plan of management. Next, grasp and release. Ultimate function of the upper limb, the terminal part, grasp and release. Both are important. The child is asked to pick up the blocks of different size and shape. You have to see cylindrical grasp, hook grasp, spherical grasp for different activities. So you have to see how the child is holding. You give different object to the child. Ask the child to hold. See how he is holding the object, whether he is able to open his hand or not. So hand opening, finger opening is important before grasping. Okay. So this test evaluates not only the prehensile capacity of the hand, but also the contribution of the whole limb to that function. How the forearm is behaving, how the elbow is behaving, how the shoulder is behaving for holding that grasp. Though the hand is only holding the grasp, but as a whole, how the whole upper limb is behaving. And moreover, you can quantify these things also by adding time. Simple introduce a time factor. How much time the child is taking for holding a glass. So you can quantify for research purpose also. You can quantify it before surgery and after surgery. The simple method. Okay. Then bimanual activities. This gives you accurate information of the spastic upper limb's actual functional ability. So most of the activities are bimanual activities. And if the child, especially when the child hemiplegic child, when you are dealing with a hemiplegic child, so bimanual activity is extremely important. With the opposite limb, they can carry something, they can catch something. So this really gives you actual functional ability of the child. Then coming to functional assessment of activity level of a cerebral palsy child, especially upper limb is concerned. We have many times discussed about the lower limb functional activity by this gross motor classification system, but here this is the upper limb assessment functional activity level classification by House et al. Okay, so broadly House et al. They have classified the functional activity level of or the upper limb of a cerebral palsy child into 3 groups: passive assist, active assist, and spontaneous use of the limb group. So first 3 are class 1, 2, 3 are the passive assist group, and 4, 5, 6 are active assist group, and 7, 8 are spontaneous use group. Okay, so what is that passive assist? That is class 1 group, poor, then 2 is fair passive assist, 3 is good passive assist. Poor passive assist means uses thus the child uses the limb just to stabilize in the weight only. And fair passive assist can hold onto the object placed on the, just you keep a object on the hand, he can hold it only, simple hold it. So this is a passive method. Somebody else is keeping the object on his hand, he cannot catch hold of the object, he cannot take the brush, somebody will have to keep the brush on his hand, then only can hold the object. Then good passive assist means can hold on to the object and stabilize it for use by the other hand. So he can stabilize the object, and by the other hand also some extent he can use it. So that is a group of patient with passive assist group. Then active assist group, again they are poor active assist, fair active assist, and good active assist. Poor active assist means can actively grasp object and hold it, but the grasp is weak, poor grasp. Fair active assist can actively grasp the object and stabilize it well, can hold it properly. Good active assist can actively grasp the object and then manipulate it against other hand. Some extent can try to use the hand. Okay, so passive basically the caregiver will keep the object in the hand, and active assist the child starts holding the object for starting with the weak grasp, moderate grasp, and good grasp. Then class 7 and 8 are spontaneous use. Class 7 spontaneous use means can perform bimanual activity easily and occasionally uses the hand spontaneously. Still is dependent on the other hand. In case of class 8 spontaneous use, they uses hand completely independent without reference to the other hand. So he can use single hand for all his activities of daily living. So this is a beautiful classification. You can remember, you can your result can be recorded by using this classification system. Another classification system by Green and Bank classification, which is modified by Samuelson and Morris. They have classified hand function into poor, fair, good, and excellent. Poor means there is no effectual use of the hand. Poor or absent grasp and release, and there is poor control. Fair means use the use of the hand as a helping hand, but no effectual use of the hand in dressing. Moderate grasp and release, fair control. In good group of hand, spastic hand, they uses the hand as a help in dressing and eating and general activities. There is effectual grasp and release, and there is excellent control of the upper limb and hand function. An excellent group, good use of the hand in dressing and eating, effectual grasp and release, and there is good control. Okay, so this is another way of classifying the hand function, upper limb function in cerebral palsy. Now coming to the how do you select patient for surgical intervention in case of cerebral palsy child? So what are the criteria for patient selection for surgical intervention in cerebral palsy upper limb? First part is age of the surgery. At what is the ideal age for taking the child for surgery? The ideal age for surgery is always controversy, and still it is a debatable situation. What is the ideal age? This 4 to 6 year age is recommended because at this age, adequate maturation of nervous system has occurred. So some authors, some surgeons, they prefer 4 to 6 year age as a recommended age. Other group of surgeon, other group of researchers, they have found 7 to 12 years age is appropriate as the children are cooperative for occupation therapy and they have enough skeletal growth has occurred to prevent recurrence due to increase of the muscle tightness secondary to growth of the child. So the 7 to 12 years appears to be more scientific. By that time, the child is an understandable age. As you know, all types of tendon transfer needs tendon re-education. Child must be enough IQ that he can follow the command. Child can follow the instruction of the therapist so that the outcome will be good. Moreover, the growth is towards terminal age. So 12 years is, I mean, the first growth is now reduced. The muscle to bone discrepancy, which is the major cause of deformity in CP, that will gradually reduces. So this is the age. I mean, 7 to 12 years is the most appropriate age for taking the child for surgical intervention. Then intelligence level. Yes, this is also important. Unless the child is adequately intelligent, at least the IQ should not be less than 90. That means child must be understandable IQ so that he can follow the instructions. So the overall result depend upon the therapeutic protocol also. And if the IQ is more than 70, then child will cooperate enough in post-operative re-education. As I said, that the post-operative rehabilitation also equally important as the surgery is. Then the surgical result also depends upon type and extent of neurological involvement. Only patients with pure spastic type of involvement are amenable for surgical correction. Overall, the results are good for a pure spastic variety of cerebral palsy. But when there is associated dystonia or arthritosis, results are poor. So better not to venture into the surgery when the child is associated with any dystonia or arthritosis. These are some extent contraindications for surgery. Then voluntary function. Voluntary function is also, one has to see that what is the voluntary control of the child, whether the child is having initiation to start any activities of daily living or not. So voluntary use of hand is an important predictor of the outcome of operation. Dissociated upper limb from body function is not an indicator for reconstruction. It's not an indicator for reconstruction. So one must be careful for that. The results are limited in learned disuse. We have already discussed that part. It's a major hindrance. Learned disuse of upper limb is a major hindrance for outcome of the surgery. Better results for those children who have impaired function but are trying to use the limb. Yes, this is a very pertinent point. Okay, if the child is trying to initiate the movement for a particular thing or particular work, okay, even there is associated impaired function, but those children will result will be good. Okay, because the child is having initiation part, he's trying to do the function. Okay, in that situation, the results are good. Sensation and sensibility, that is also important. So one must sure that child has their sensations are preserved. At least touch pain sensation must be there. Stereognosis is important. Preservation of basic sensation of touch and pain. Ability to recognize the physical characteristics of the touched object, consistency, shape, size, surface without aid of sight. Okay, I mean, many times the child compensate by its visual input. Though the stereognosis is poor, but still the child can compensate with a visual input. That's why when the child is having a severe pronation deformity, thumb in palm deformity, he cannot see the object, but he is holding. So he will confuse. He will the function will be poor in case of pronated hand. Okay, many times that is compensated by visual input. The proprioception and 2-point discrimination deficits are also need to be evaluated before planning for surgery. These children do not use their affected upper limb spontaneously unless compelled to do so. If they have any stereognosis problem, if they have proprioception problem, these children, they do not use their affected limb unless they are forced to do the activities. They always hesitate to do that. So if child is hesitating, is not initiating, so you should look for that whether child is having these deficits or not. So this is also another important factor. Surgery may improve the function of the hand, but does not reintegrate independent function in majority of the cases. And that could be the reason that maybe the stereognosis is poor, maybe its sensory inputs are poor. Okay, so one must evaluate properly before going for surgery. Many children effectively use hand-eye coordination to compensate for a defect in stereognosis and proprioception, particularly if they have good voluntary control. I have already explained in case of hyperpronate deformity, the child cannot see the things he is holding because forearm is preventing his vision on the object. So many times they compensate it. So please ensure that the child is not compensating or he is not using the visual input. So the child has to be thoroughly investigated for these sensations and sensibility. Then, who are the ideal candidates for surgery? Overall, a cooperative child of more than 6-year-old age group with a stable family support. Family support is important. They have a great expectation. They think that after surgery, after stitch removal, the child will do all his activities of daily living after surgery. So the hope, the child, the family has to be well counseled, and you should assess what is the extent of family support towards the child for this surgery. Predominantly spastic upper limb deformity. As I said, when it is associated with dystonia, the results are poor. When it is associated with ataxia, athetoid, the results are poor. So the ideal candidate is always a predominantly spastic type of cerebral palsy. And child should have satisfactory hand sensibility. Already discussed. So the ideal candidates are hemiplegic, monoplegic children, or diplegic without any neurological sensory deficits. Okay, so these are ideal candidates for surgery. Then staging of the surgery, whether to go from distal to proximal or proximal to distal. How do you correct? So always look for the limb as a whole. Start proximally. See what is happening in the shoulder joint, what is happening in the elbow joint. But many times the child can compensate by shoulder movements. Shoulder has a wide range of movements. Many times child compensate by the shoulder movements. So if possible, give attention to the shoulder joint. If there is a gross abnormality restricting his hand function or forearm function, look to the shoulder joint. But many times shoulder is excusable because of a wide range of motion, and it is the distal part which needs active intervention, especially forearm, wrist, thumb, and finger deformities. These things can be done on a single stage. Then before venturing to the surgery, one has to be evaluate the limb as a whole, as a global function of the limb, as well as also specific problems, specific deformities around the specific joints. So the common deformity in case of spastic child in cerebral palsy is shoulder is in internal rotation, elbow is in flexion, as you see in this picture, shoulder internal rotation, elbow flexion, forearm pronation, wrist flexion and ulnar deviation, thumb in palm, either clenched fist deformity or a swan neck deformity of the fingers. Okay, so these are classical problems in a upper limb. You will see in case of spastic cerebral palsy children. So deformity correction is mostly directed towards pronation deformity of the forearm. As I said, the shoulder is most of the times is a forgivable joint which has a wide range of motion that can be compensated. So many times shoulder requirement is very limited. So most of the times the treatment is directed, the surgery is directed towards the forearm and hand. So the prominent deformity need to be corrected are pronation deformity of the forearm, wrist flexion deformity, swan neck deformity of the fingers, thumb deformity, or a clenched fist. So these are the deformities which needs to be corrected. Is a flexion deformity, extension deformity thumb, thumb in palm deformity, and swan neck deformity. Coming to pronation deformity at the forearm. This decrease the sight of the object being grasped and thus obstruct the visual stimulus in the patients with compromised stereognosis. I already explained that. That if the child is having a compromised stereognosis, so this hyperpronated forearm will cause obstruction in visual stimulation. So the grasp will be poor. The child cannot hold, even the grasp is hand grasp is there, but he cannot hold it because he cannot see the object. Okay, so for evaluating this forearm, start with try to passively supinate the forearm and palpate the pronator teres, whether it's taut, but it's cord-like, palpate it. So first part of the evaluation of the forearm is passive supination of the forearm to palpate to see the tightness of the pronator teres. The second part is evaluate both active and passive pronation, supination and pronation. Both active supination and pronation. Ask the child to do as much as supination possible, as much as pronation possible. Okay, and third thing is that what is the position of the forearm at rest? Observe the child in rest condition. What is the position of the forearm? Whether the child is keeping the supinated position or it is keeping the pronated position. As I said, these are all dynamic deformity and the spasticity increases with the movements. Okay, so you have to see active motion, you have to see passive movement, you have to see the movements or the position of the forearm at rest. So these are 3 points one must observe the forearm. So this is a classical flow chart of planning forearm correction or forearm pronation deformity correction in case of cerebral palsy child. Dear friends, please take a note of this table. This is very, very important for a planning of management. You can keep table with you at whenever you come across a child with cerebral palsy having a forearm problem, pronation restriction or supination restriction, you can use this table for your management. So this is by Token and et al. Published in JBJ's Journal of Hand Surgery, British journal. So they have classified into 4 groups. Group 1, there is active supination beyond neutral. As I said, always assess the patient, actually asking the child to actively supinate it. Ask the child to supinate the forearm. Okay, if the child can supinate the forearm beyond neutral position, no specific treatment is required. No specific treatment is required. Okay, so if there is some restriction, then coming to it comes under group 2. Okay, group 2 includes active supination to less than or to neutral position. It is just less than neutral position. That comes under group 2. So what is the recommended procedure? Pronator quadratus release. Pronator quadratus release, not teres release. If there is a gross limitation after releasing pronator quadratus, supination pronation, see it passively how it is coming. If still tightness is there, then you may or may not go for flexor aponeurotic release. So in case of active supination is less than neutral position, pronator quadratus release, not pronator teres release. associated with flexor apponerative release. We'll discuss flexor apponerative. What is that flexor apponerative release? So group 2 varieties, pronator quadratus and flexor apponerative release. When the child cannot actively supinate the forearm to mid prone position or to the neutral position. Okay. Then group 3 includes children having no active supination, but the passive supination is full. You ask the child, supinate, he cannot do it, but you can passively supinate. That means the forearm passive supination pronation is free. So this is a favorable condition for tendon transfer. The principle of tendon transfer, that wherever you transfer a tendon, the joint must be, there should not be any fixed deformity. Here, since the passivity supinator pronator is possible, there is no fixed deformity, you can go for pronator teres rerouting. Pronator teres rerouting, making pronator to supinator. Okay, that is for group 3 patients of cerebral palsy with a pronation deformity. Group 4, no active supination, no passive supination. It is so much rigid that there is no active, no passive supination. Then you have to go for pronator quadratus release, flexor apponerative release must, and if required, pronator teres release also. Pronator teres release also. So this is group 4. So this is a simple way of deciding what procedure need to be done for a hyperpronated or a forearm deformity. Next, wrist and hand deformities. The common deformity is wrist flexion deformity. Okay, so position of the wrist is very important for any sort of grasp. Okay, the wrist, for a good grasp, wrist must be extended and ulnarly deviated. This is for a, you can try on your grasp. Your grasp will not be that far when you try to catch hold or grasp an object in wrist flex position. So wrist must be in a ideal position for a good grasp. The flexor contraction of the wrist weakens the flexor group of muscles for grasping an object. That means the wrist flexion must be corrected for bringing the flexor group of muscle to a adequate position to prevent an active insufficiency for a wrist and hand. Okay, and there is co-contraction of the flexor carpi ulnaris during the flexor that must be looked for. Ask the child to hold the object. See how he is holding. So in our video, you can see that the child is holding his foot in wrist flexion, finger flexion, ulnar deviation. That's because the spasticity of the flexor carpi ulnaris, which is very often spastic in nature, there is always co-contraction of the flexor carpi ulnaris along with the long flexors, bringing the hand flexion and ulnar deviation, which is a disadvantaged position for a good grasp. Okay, so with better wrist position after surgery, the active finger flexion and grip will be improved. Okay, so wrist position is very, very important. So for this management of hand, there is a beautiful classification by Jankoli. Everybody knows about this. This is a very popular classification, widely accepted by all group of surgeons, therapists. Everybody accept this Jankoli's classification of spastic hand. So what are these things? These are the 4 pictures depicts the Jankoli's classification type 1. If you look to this picture, type 1 Jankoli's hand, the fingers can be completely extended with wrist in neutral position or in slight flexion, and flexion must be less than 20 degrees. So ask the patient to extend the fingers with extended wrist. If the child can extend the fingers with wrist in extended position or wrist flexion within 20 degree flexion, then that comes under type 1, Jankoli's type 1 group. Then Jankoli's type 2. Jankoli's type 2 means the finger can be extended with wrist in flexion. The fingers can be extended with wrist in flexion. That comes under Jankoli's type 2. And Jankulis type 2 again divided into subgroup Jankulis 2A, Jankulis 2B. Jankulis 2A, this is Jankulis 2A. That is active extension wrist is possible with fingers flexed. See in this picture, with fingers flexed, the wrist is extended. That is Jankulis type 2A. Type 2B, the wrist cannot be extended with fingers flexed. That is Jankulis type 2B. Okay, and Jankulis type 3, no active extension of finger is possible with maximum wrist flexor. Look to this picture, with maximum wrist flexor, the fingers cannot be extended. So this is Jankulis classification. We'll discuss individual pathology or pathoanatomy in each group of Jankulis classification system and how we'll go ahead with surgical intervention. Okay, so this group 2 patients, these group 2 patients are ideal candidates for surgical intervention. These group 2 patients are the ideal candidates for surgical intervention. So better ability for grasping obtained by extension of their fingers with small flexion of the wrist is required. Okay, in most spastic hand, the flexing of the wrist actively is fundamental for releasing the hand. This is a common attitude for a CP, a spastic hand. Whenever you try to grasp a object, he has to flex it so that the spastic flexors will be relaxed and the child can extend the fingers. This is a normal tendency in a spastic hand, always with a flex wrist. Hence, wrist fusion is not a very useful operation to improve functions. In contrast, in case of VIC, in case of other varieties of lower motor type of flaccid paralysis, we go for wrist arthrodesis. We stabilize the wrist, then go for tendon transfer. But in case of cerebral palsy, wrist fusion is not ideally advised, because even after surgery, the child may still depend on some amount of wrist flexion, because 20-degree wrist flexion is still permissible for hand function to come under Jankulis type 1. Okay, what are the surgical limitations? What are the limitations of the surgery when the patient has no active wrist flexion and the fingers remain permanently flexed? Reconstructive surgery is not indicated. Dear friends, please remember, when the patient has no active wrist flexion and the fingers are permanently flexed, so we don't have any tendon to transfer to the dorsum for opening the fingers. So this is a contraindication for the surgery. So you can take it as a Jankulis 4. Then transfer a wrist flexor to obtain a wrist extensor must consider the ability to retain wrist flexors by flexor. Yes, when there is option, what flexor to be taken to dorsiflexor, always try to keep the FCR, flexor carpi-radialis. Try to take the FCU, that is a muscle which co-contract always with the long flexors. That's the ideal muscle to transfer the dorsum for opening the fingers. So try to keep FCR. If you take FCR, the child will develop an extension deformity. So it is not advisable to take flexor carpi-radialis. Okay, this is again modification of Jankulis classification for voluntary grasp and release pattern. This is just similar way in a functional, it is described. Level 1, there is a minimal flexion spasticity, and describing that full active finger extension possible with wrist in neutral extension or less than 20 degree flexion. The same as normal classical Jankulis classification 1. Jankulis 2, this is moderate flexion spasticity, where the fingers can be actively extended but with more than 20 degree of wrist flexion. Again classified subgroup A, 2A, subgroup 2B. Subgroup 2A can actively extend partially or totally the wrist with finger flexed. Okay, already shown in that picture. And 2B cannot actively extend the wrist with finger flexed because the paralysis of the wrist extensors. Why it is happening? Because of the basically it describes about the power of the voluntary control of the ECRB, whether the extensor carpi radialis brevis is there or not. The whole system is moving around that. Okay, so if ECRB is there, then your role is now to augment the finger extension. Your role is now to relieve finger spasticity. So this Jankolis type 2 is moving around the presence of voluntary control over the ECRB, extensor carpi radialis brevis. Okay. Now coming to treatment part as per Jankolis classification. Jankolis classification 1. What will the treatment? What is Jankolis classification 1? That the fingers can be extended with wrist in neutral position or less than 20 degree of flexion. So what to do? This is a normal function. One can manage with that. Yes, you need not to go for any sort of treatment. But if you feel that the FCU is spastic and that 20 degree flexion is because of FCU, you can go for reduction of spasticity of FCU by buttocks injection or by tenotomy of the FCU. Best way to go for buttocks injection, botulinum toxin. So this is probably not much treatment is required for Jankolis type 1. Jankolis type 2A, the spasticity is localized to finger flexors. And mostly it is because of flexor carpi ulnaris. But the extensors are active. Please remember here, the extensors are active, especially ECRB is acting. So what is our role? Our role is to reduce spasticity of the finger flexors. Okay, how to do? By going for a flexor aponeurotic release. We'll discuss what is that. Very simple surgery, flexor aponeurotic release and fractional lengthening of the finger flexors at the musculotendinous junction, not tenotomy. Okay, if at all if the flexor component is much severe, you can go for tenotomy of the FCU, flexor carpi ulnaris, if it is very spastic. But in case of 2B, where the extensors are not active, ECRB is not active, okay, there you need to augment the extensors by transferring FCU to ECRB. So that means now your extensor, you have converted type B to type 2A by transferring the muscle FCU to ECRB. Now your role is to release the spasticity of the flexors, again by fractional lengthening or by flexor aponeurotic release. Okay, that is 2B. And type 3 Jankolis, there is a marked spasticity of the wrist and finger flexors and paralysis of the wrist extensors. So with maximum flexion also, the child cannot extend the fingers. That is Jankolis type 3. These are the poor candidates for the surgeries and aim towards the improve the function. They can be alternatively treated. Only the treatment is directed towards reducing spasticity, but these are not ideal candidates for surgical correction. So as I was telling that flexor aponeurotic release, very simple procedure and technically not demanding, very simple procedure. Just a transverse incision is given on the flexor aspect of forearm around 4 fingers from the elbow crease, say around 6 centimeters from the medial condyle of the humerus. 4 fingers from the flexor crease, give a transverse incision, expose the deep forearm fossa, release the deep forearm fossa. You can excise 2 centimeters of the forearm fossa, deep flexor fossa of the forearm, and also you can excise or incise intermuscular septum. So this flexor aponeurotic release includes incision of a portion of the deep fossa of the flexor aspect of the forearm, which is done around 6 centimeters below the medial epicondyle, and you can go through, just dissect the muscles, go through inside the intramuscular septum. There will be reduction of this spasticity. Okay, so this is simple procedure, flexor aponeurotic release. Anybody can do it. Then next, if the ECRB is there, but still the fingers are not well powered to extend it. So you can go for release of the flexor opportunity release by relieving spasticity of the long flexors. Also, you can augment the extensors. Extensors can be augmented by transferring FCU to EDC. This is case we have recently operated. Transport flexor carpi ulnaris. Here we have isolated flexor carpi ulnaris. This is flexor carpi ulnaris isolated completely. We have divided in, since it's a thick muscle, difficult to pass through the extensor digitorum tendons. Yes, small slips. So we have divided the FCU into two parts. The one part will pass through the medial two tendons for the extensor tendons, and other part will pass through the lateral two extensor tendons. Okay, by that you can augment the extensors. So now you have relieved spasticity, the flexor spasticity by taking out the FCU. You have augmented the extensors by transferring FCU to extensors, and as such ECRB is there to extend the wrist. So that will complete your procedure, balancing the fingers, balancing the muscles around the wrist, around the MCP, and around the IP joints. Next part, deformity is swan neck deformity. It is just like swan neck deformity in rheumatoid arthritis. There are two prominent causes of swan neck deformity possible in case of cerebral palsy child. In extrinsic type, the main cause is the overactivity of the long extensor tendon, especially the central slip of the tendon, extensor tendon, and that stretches the volar plate, leading to hyperextension of the PIP joint. So the main cause is the stretching of the volar plate and hyperextension of the PIP joint because of the tense central tendon of the long extensor. How do you manage? You can just go for a tenotomy of the central portion. You just keep the collateral intact. The central portion, central extensor tendon is just cut. That is one procedure, or else you can go for application of the FDS, flexor digitorum superficialis, to be tenodicized, plicated, to keep the fingers in the IP joint in PIP joint in flexor. Okay, that is how you can manage swan neck deformity. Other splints are there, also you can manage, but permanent solution to this, when the deformity is very severe, you need to plicate the FDS, or you need to go for incision or excision of the central extensor tendon, central slip. Thumb is a major problem in spastic hand. Many times they present with a thumb in palm deformity. You can sit here, thumb in palm deformity. Whenever the child try to open the hand for holding an object for a grasp purpose and try to going to catch hold the object, the thumb is coming in front of the object. So the grasp will be poor. Thumb is a major hindrance for impaired grasp. Okay, so this is because of lack of abduction and extension that limits the size of the object, because he cannot open the hand properly. The thumb is always come in front while while grasping an object. The thumb in palm also obstructs the function of the other fingers also. This also obstructs the function of the other fingers. And that is a major problem, is that is a major hindrance for the personal hygiene. Okay, and that's the reason why the child rejects the hand for its use. So this thumb management should be given as utmost importance as far as the spastic hand is concerned. So what are the key things to need to be examined for a thumb deformity in spastic hand? It's because of spasticity of the adductors and flexors. That is adductor pollicis, flexor pollicis brevis, and flexor pollicis longus. These are the three muscles which are often spastic and major cause of thumb in palm deformity. Okay, and they are associated with weakness of the extensors and abductors of the thumb. In long run, they present with hypermobility of the MCP joint. You will find the thumb in extended deformity. thumb in extension deformity that is possible when there is a hypermobility or laxity at the MCP joint. Instead of thumb in palm, the patient will develop an extension deformity at the MCP joint. In long run, they also develop web space skin contracture. Even after tendon transfer, also still the thumb remain in adducted position, flex position. So I will give you a simple way of analyzing thumb in palm deformity. Again, I suggest please keep these two tables with you. Please take a screenshot of this table. This is very, very important. So to a few days back, we operated Abhishek and me. We have operated one thumb in palm. At that time, probably we have not properly followed this table, and maybe we have took a wrong decision that time. But this table is very, very important for as far as thumb in palm deformity is concerned. So that's why I suggest all my friends, you just keep a screenshot of this table. This will certainly help you managing thumb in palm deformity. So there are 6 types of thumb in palm deformity. The type 1 indicates simple metacarpal adduction. Simple metacarpal adduction is not visible to out. It is inside the palm only. Okay, but that is a major hindrance for the function of the thumb. Here, it's because of adductor pollicis spastic in nature. So that needs release of the adductor pollicis tendon. We are trying to extend the thumb by transferring palmaris longus to the extensor pollicis longus, but that is not the treatment. So you have to see what is the status of adductor pollicis. That is the major cause of adduction of the metacarpal, which limits the abduction of the thumb. Second is metacarpal adduction with MCP flexion. The second part. This is the major types of presentation in case of spastic hand. The thumb in palm deformity is because of metacarpal adduction and with MCP flexion. That is because of adductor pollicis along with flexor pollicis brevis spasticity. And you need to release those 2 tendons to correct the deformity. Type 3 varieties is uncommon. It is associated with metacarpal adduction with MCP hyperextension. This is because of a unstable MCP joint, lax MCP joint. Okay, that needs stabilization MCP joint, maybe by arthrolysis or by KVL. Type 4. Type 4 is type 2 along with IP flexion. So metacarpal adduction, MCP flexion along with IP flexion. Type 2 plus IP flexion is the type 4. So IP flexion means along with FPL is also tight. So you need to release adductor pollicis, flexor pollicis brevis, and flexor pollicis longus. That is type 4. Type 5, IP flexion with less marked metacarpal adduction. This is a special type where metacarpal adduction is not so prominent, but IP flexion is there. So you need to go for release of a flexor pollicis longus. Then type 6 varieties, weakness of the extensors associated with the tightness of the spasticity of the adductors. There is weakness of the extensors. Okay, and there is less marked spasticity. So deformity is not because of spasticity, it is because of the weakness of the extensors, weak extensors. There you need to go for a augmentation of the thumb extension and abduction. That is also important. What muscle need to transfer to augment extension and abduction? We'll discuss. So the major problem of the thumb deformity is the position of the thumb in palm during the fisting. In fisting, it is always in the hand, coming act as a hindrance. Okay, the inability to abduct the thumb when opening the hand because of the weakness of the abductors and extensors. The 6th variety is weakness of the abductors and extensors. So the key concept is to balance the force by decreasing the deforming force and augmenting the opposing force. Okay, so and at the same time also you have to stabilize the unstable joint, that is MCP joint. So what are the procedures? So as I said, the abduction and the abduction and extension is important. So the simplest procedure is rerouting the extensor pollicis longus if there is no fixed flexion deformity. Okay, or augmentation of the abductor pollicis longus, extensor pollicis brevis, or extensor pollicis longus, or augmentation of extensor pollicis brevis is always preferred as it brings the thumb in abduction and extension. Abduction and extension. Please again remember, EPB, extensor pollicis brevis, is a important tendon among all these tendons. If any tendon need to be transfer into the EPB. But this acts in both the way. This helps in extension. This helps in abduction. This tendon transfer to augment thumb extension leads to, if you don't do that, if the simple transfer to EPL, it will cause thumb extension, as we have done in last case. So that patient may land with a thumb MCP hyperextension. Okay, so in that situation, joint stabilization may be required, like capsulorrhaphy or arthrodesis or complete fusion of the joint. Whether it will be helpful or not, in first stage we can go for with a caber stabilization, see how after stabilizing the MCP, how the hand is functioning. It is functioning better, then take out the caber and fuse it permanently. MCP joint. Okay, we are towards the end of this presentation. That the last classification or assessment system for the hand is a manual ability classification system. I know everybody, I hope everybody knows about this. This is a classification system which is used for assessment of disability percentage. In case of cerebral palsy children, we assess ambulation by gross motor classification system, GMFCS, and hand function by manual ability classification system. We add these values by addition formula in the disability calculation. So I deliberately put this slide here because this is also important assessment system for the upper limb in case of cerebral palsy. So this is classified into 4 levels of manual ability classification system. Max level 1 is objects are handled easily and successfully. They do not require bimanual activities. Okay, and level 2, they handles most objects but with some reduced quality and speed. They can handle the object but with lesser speed or lesser quality. And type 3 handles object with difficulty. The child will need help to prepare and modify the activity. He will grasp the object but in a different way. Type 4 handles limited selection of easily managed objects and always requires some help from others. Type 5 are complete dependent. Child is not able to handle any object or complete even simple action with their hands. So this is completely dependent. Child is max level 5. So this is a simple functional evaluation of the upper limb for assessment of disability. This is especially used for children of 4 to 18 years old age. Yes. Okay, this is all about my principle of evaluation and principle of management protocols for management of upper limb in cerebral palsy. Yes, one more thing, parent council. I forgot to tell you, the parent council is essential, very, very essential for whenever you are venturing for surgery. This has a unique role in management of CP patient because the expected functional recovery must be explained to the parents. This is a condition where the primary pathology is the brain. You are treating the peripheral pathology. So child will not able to get back his normal function. However, we are trying to make the child independent. We are trying to improve the function of the hand function. But be assured the parents that the surgery is not going to completely cure the hand function or the hand problems of the child. The surgery is done to improve the function and appearance of the hand. The discussion should always end on a positive note, since many children can be made better with intervention either in the form of therapy or in the surgery. So surgery is an additional thing. Always we try to manage first with therapy and splinting, when we see that the augmentation is required, only spasticity reduction is not enough. Whenever we evaluate that, the stabilization of the joint is required. So there you need to go for surgical intervention, and surgeries are not technically demanding. Surgery is a simple procedure. Only thing is that you should know how to evaluate, how to plan the particular condition for surgery. And my suggestion, please take a screenshot of those protocols of management. I have shown you 4 or 5 things I have collected from different articles. So these are very, very important for planning for management a cerebral palsy child. Thank you. Thank you very much.
Thank you so much, sir. Thank you so much for such an elaborate overview of cerebral palsy and its spasticity hand management. I'm sure that most of the people who have been listening the whole session, they must be excited, and I think the court is open for asking the questions, and we can go ahead with the discussions.
I expect some questions from Amit.
I will encourage the participant to put their questions in the chat box.
See, it is a bilateral discussion. Unless you people are not involved with us, so all our efforts to bringing all these data as documents in front of you are going to waste. So you should involve in this discussion. It should be a bilateral discussion. If you have any queries, you can ask here. And I think recording is going on, and these slides are available on the YouTube also. You can go through these slides repeatedly, and you can plan your management for managing the spastic hand.
So first question has come: what classification system can be used beyond 18 years for hand function?
See, as far as the disability evaluation is concerned, still this is the MAC classification is available for that, though it is meant for up to 18 years, but this classification can be used at any year, any age. This classification was meant for child of up to 18 years age, but this classification used whenever you are used for the disability assessment, there is no age bar. And this is a class system, the classification which is used for the functional purpose only. This classification will not be helpful for deciding any surgical management. So age bar is done by the person who has designed this classification system, but actually the age bar is not there whenever you are using this classification for evaluating disability.
I think this answers the question. Sir, what can be the appropriate age for surgery? Is it around 6 to 12 years, or will it be? How will you consider the surgery? Like what will be the optimal time?
See, the whole thing is moving around that. What is the extent of IQ of the person, IQ of the child? What is the extent of involvement? What is the extent of initiation of the child for different activities? So the age bar 6 years is meant for that only. Child must be an understandable age. Child must respond to your command, respond to your instruction. That's why the age bar is there. But the upper age bar is not there. Only thing is that the ideal age is in adolescence 6 to 12 years, but any age can be taken for surgery. Only thing is that as the child grows older and older, what will happen? The deformities become more static in nature. There will be fixed deformity. So the whole principle of tendon transfer is that joint must be supple enough for tendon transfer. There should not be any fixed deformity. As the child grows, the deformity becomes fixed. That's why the results will not be that encouraging as the age group between 6 to 12. But there is no limit, upper age limit. Any age can be taken.
So another question: how long should conservative management be done?
It depends on what deformity you are dealing with. Whether you are deformed with thumb in palm, where you are dealing with a pronator and a hyperpronated forearm, you are dealing with a fixed, flex hand, flex wrist. Depending upon that, yes, any type of deformity, if it is purely spastic, there is no the antagonist group of muscles have adequate voluntary control. Then you can go for conservative method. You can go for reduction of spasticity, or then by splinting, or by stretching, or by injection botulinum toxin. So up to that you can go. But when you feel that the antagonistic group of muscles are not well powered, or voluntary control is not enough to prevent deformity in future, probably that is situation where you need to go for surgery. So any case, you try with the conservative method, nothing harm in that. Try with the conservative method. But when the conservative method fails, or when you, in your protocol of assessment, you found that the opposite group of muscles are still weak, the voluntary control is poor, the opposite group needs augmentation, then there is no other way. Any permanent solution if you want, then you have to go augment the opposite group by end-to-end transfer. And they are very simple procedure also. It's not so difficult. They are not technical demanding.
How do you take up, sir, for upper limb or Botox versus phenol block or alcohol block?
For upper limb, Abhishek, if you can answer, it's better. You will better answer than me. Please explain.
Initial discussion, no.
A phenol block, we don't encourage phenol block. It's not a permanent deformity, or it's not an end-stage procedure. We never prefer phenol for the upper limb. You always prefer botulinum toxin rather. And again, it is depends upon the what deformity, what problem the child is facing. Suppose you are facing with a flexion ulnar deviation, the hand grip is poor. Of course, you will go for the buttocks to the FCU. This is standard procedure. How you give buttocks to different flexor group of muscles. There is nothing different in this such situation. The same as other spastic hand. How you are dealing, how you are giving injection buttocks to the spastic group of muscle. Only thing is that by this presentation, you will try to find out which is the culprit muscle, which is the culprit muscle which is causing or hindering for this activities of daily living.
Okay, I think Dr. Pavitra sir has answered most of the questions quite clearly, and I hope this session was really useful for most of our participants. And yes, I have also seen a lot of slides. They are really knowledgeable. There is a last question which is coming up. That is, can we do surgery? The question is, can we do the surgery in hemiplegic non-dominant hand also?
Yes, why not? Hemiplegic, they are good candidate for surgery. Always we need a two hand for our functional purpose. We cannot neglect a opposite hand. Rather, these hemiplegic patients are good candidate for surgery. You just see what is happening. Suppose somebody is having a thumb in palm deformity for a left hand, non-dominant hand. Of course, you will go for surgery or any other model management for hygiene purpose. So it is not about the hemiplegia. Rather, hemiplegic patients are good candidate for surgery.
Okay, with this, I think we can call for the session. And it was a really great opportunity to listen Dr. Pavitra Sahoo and seeing him answering the question. I think we'll be coming up with more academic sessions like I'll take opportunity and I'll thank everyone who has been present throughout the presentation. And I'll of course thank Dr. Pavitra Sahoo for delivering such an knowledgeable lecture at this junction. Thank you so much.
At the end, Abhishek, we should not forget to thank the IAPMR PR team, which is extending us this Zoom platform for organizing this webinar. And I must thank all office bearers of APMRO and all my PG students, my faculty of my department for supporting such type of academic activities. Thank you all. Thank you all participants for joining this webinar. Thank you.